Okay, right, ready to go. Welcome everybody to this fifth and final part of our dementia webinar series. Today's webinar is addressing some of the legal issues that can come across our managing cases of dementia. The focus of it will be on capacity, and to present the topic we've got Dr. Vicky Brown, who's one of the consultant Age Psychiatrists, and we've also got Dr. Allison Hibbert, who's been a stalwart presence throughout and is the Dementia Lead for NHS Kernow. Without further ado, let's kick off.
Thank you.
Hello, nice to be here.
Hello.
So, should I just start?
Yeah.
With the slides. So, thank you, Alison, for asking me to talk about this. So, this is just mainly talking about capacity, but the slide isn't changing like it was earlier. What's happened now? The scope is to talk a bit about mental capacity versus the Mental Health Act, to look at just the basics of the Mental Capacity Act and capacity assessment. I'm going to go very briefly over tech forms, but I understand you've done them already with Jay.
Yeah, but a little bit around capacity would be helpful. It's always a challenging topic.
Then to look at capacity for power of attorney, wills, place of abode, medication, hospital admission, just a few things that commonly crop up. To think a bit about some of the forms we get asked to sign, power of attorney, deputyship, appointeeship, COP3 forms, which crop up quite a lot. And then a last little thing about driving. And
really important.
It is, driving's difficult, isn't it? And at the end, I've got some resources. So I'm very wary that I'm teaching people to suck eggs, because I bet most GPs do this all the time. And I am really sorry if what I'm saying is too basic or a bit patronising. But it's just worth repeating some of this stuff. And also, if you're going to cover it, you need to sort of start from first principles.
Yeah, definitely.
So this is a flow chart I made for the ward about which legal framework to use. But I realised when I look at it, it misses out an important stage, which I've scribbled in red. So first of all, you have to decide whether the person's got a mental disorder. Now, if they haven't, then neither DOLS nor the Mental Health Act is appropriate. So we just give up and we can't do anything. So much as you'd like to get rid of the Prime Minister or whoever, and unless they've got a mental disorder, we can't really use the Mental Health Act or the Mental Capacity Act. So once we've established that, and the definition is slightly different in each piece of legislation, which I'll come on to, we have to decide on whether they have capacity to decide on whether they're going to be in hospital. Now, if they do agree and they've got capacity, then it's easy. They just come in as an informal patient. If they don't agree, but they've got capacity, then you've got to think about whether the Mental Health Act is appropriate, and which probably isn't too relevant, I guess, unless you're deciding whether to detain somebody if you're in the community. So where we come in, really, the Mental Capacity Act, is having decided the person doesn't have capacity, then we have to think about, is there a DOL, a deprivation of liberty? If there isn't a deprivation of liberty, then we can just use the Mental Capacity Act. So that's when we might admit somebody who doesn't have capacity, they're going to somewhere like Trelisk or a community hospital, the doors aren't locked, they're not under constant supervision. So you can just use the Mental Capacity Act. But if there is a DOL, a deprivation of liberty, then we have to start thinking about whether we use a DOLS order or the Mental Health Act. And this is somewhere where the case law changes and evolves, but where it is at the moment is that the first, or one of two things to consider is it for the protection of others, or is it in the person's best interest? Because if it's for the protection of others, then the Mental Capacity Act doesn't come in. You have to use the Mental Health Act. Then also, are they objecting to their treatment? Because if people are objecting to their treatment in hospital, and it's a psychiatric hospital, then you have to think about the Mental Health Act. If it's another kind of hospital, then you can think about DOLS, but it depends on the environment. So it is quite until I drew the little line, the flow chart, I didn't realise, gosh, that is a really tricky set of things to measure up. So the definition of what the mental disorder is slightly different. So in the Mental Health Act, you've got to have a mental disorder of nature or degree for the health, safety, protection of others. Mental disorder includes learning disability. In the Mental Capacity Act, it's slightly different. So it's an impairment or disturbance in the function of the person's mind or brain, and that can be temporary. So it does include intoxication, which isn't included in the Mental Health Act.
No. Okay.
Which is very important, not so much in our field, but in capacity to consent to sexual relations, and why that's an issue that's come up in law a few times.
Okay, yeah.
So who should think about the Mental Capacity Act? Us, really, or anybody who's acting in a professional capacity for a person who lacks capacity. And the term "a person who lacks capacity" is it means that particular decision at that time. So capacity decisions, somebody might have capacity one moment, but they might not have capacity later. And that's really relevant if, for example, somebody is at home and sometimes they're agreeing to have care and sometimes they're not because their capacity is fluctuating. And I think you often have to look at a legal framework that encompasses the scenario when the person isn't able to consent. It doesn't have capacity.
Okay.
So it can be all sorts of simple things, day-to-day matters, whether to have a cup of tea, what to wear, or life-changing events, like, you know, a hip operation or going into care. It doesn't cover getting married, all sorts of personal things, really, civil partnership, having your children adopted, or donating your eggs or sperm. So those things aren't covered, and if you want to look at those things, you have to go to court. Also not covered in the Mental Capacity Act are things that would be covered by the Mental Health Act, so that's treatment that's not in the person's best interest or against their wishes for mental health disorder. Voting, neither the Mental Health Act nor the Mental Capacity Act stop people voting. Anyone can vote. And it also likes to make clear that we can't kill people, which is very reassuring. Nothing affects the law regarding murder, manslaughter or suicide. So behind the Mental Capacity Act are 5 statutory principles that you have to assume each time that you're going to assess someone's capacity, or you have to have regard to every time you go and assess somebody's capacity. So first of all, you've got to assume that they have capacity until you've proven that they lack it. Just because somebody makes a bad decision or because they've got a diagnosis that might affect their capacity or they've lacked capacity before, none of that counts. You've got to assume that they've got capacity until you've proven that they haven't. You've got to take all practical steps to enable somebody to have capacity. So help them hear. Some people are much more confused late in the day, so try and see them earlier in the day. Sometimes people need a really quiet environment without distractions. So you've got to maximise the person's potential, really. The third one is just because the decision's unwise doesn't mean the person lacks capacity. So we might say that lots of things we do are unwise, like getting married or going skiing or being on reality TV. Those things are all unwise, but it doesn't mean you lack capacity. They're just, well, I wouldn't say getting married, but you know, people have different views.
Yeah, that can be quite difficult because what you might view as an unwise decision by the people, you have to kind of respect
people's choices, and it's a very, very, very difficult sometimes choosing to get married. Their capacity proof. So the fourth one is if you're taking a decision for someone else, it has to be in their best interest. You can't do it for the best interests of others. You can't do it because it's more convenient. And in fact, I think the Mental Capacity Act has been very good at making sure that we act more in people's best interest rather than, well, it's convenient for us, or it's cheaper for us, or whatever. We have to act in the person's best interest. And then the fifth one is that you have to look at what's least restrictive. So I'll go through them again because they are so important. So in essence, they're just don't assume someone lacks capacity. Take all steps to make sure people have capacity. Just because it's an unwise decision doesn't mean the person lacks capacity. Act in the person's best interest and do it in the least restrictive way you can. So then once you get to assessing the person's capacity, there's a two-stage test. There's a diagnostic test and a functional test. The diagnostic test is, does the person have an impairment of the mind or brain, or is there a disturbance temporarily affecting how they work? So that could be delirium or intoxication. If they haven't got something wrong with their mind or brain, then you can't go any further. The Mental Capacity Act stops. And that's something that it's really easy to overlook. So you sometimes find, even on our ward where we use the Mental Capacity Act all the time, that we'll say, well, we better organise a best interest meeting, and then we get to the best interest meeting and realise no one's actually assessed the person's capacity about it. And what the disorder is. So examples of impairments, dementia, some forms of mental illness. Not everyone with dementia lacks capacity, you know, that's really important to say. Brain damage can affect your capacity, delirium, concussion, and drug or alcohol use.
So depression could.
Depression could, yeah.
Not always.
Yeah, it really depends on their decision-making powers. And so depression can affect your capacity because you might not be able to understand information. You might not actually understand the situation because you've got such nihilistic delusions. You think everyone's going to die, there's no point, so there's no point doing anything. Or your attention is so impaired you can't retain information. So or you might be too anxious to weigh it up. So there's lots of different ways a mental disorder can affect your capacity. And that takes us so nicely, thank you, Alison, onto the functional test, which is, can the person understand, can they retain the information, can they weigh the information, can they communicate it? And we say these things all the time, but what do they actually mean? So can they understand? Well, first of all, before you can assess whether somebody understands something, you have to understand it. So I would be rubbish at assessing somebody's capacity for a neurological procedure, say neurosurgery, because I don't understand what the side effects and what the benefits are. So you need to know what the different arms of the decision tree mean before you can assess someone else's capacity. If you're assessing someone's testamentary capacity to write a will, then you need to know roughly what the size of their estate is, how many possible benefactors there are, what their interests have been in life, so that you can assess whether they're taking all that into account. So before you can assess if someone else understands, you have to understand, I think. And understand doesn't mean, it used to be understand and believe. They've clarified that to just understand. So the person doesn't have to believe something. You don't have to believe that what advice I'm giving you about a medical process is true, but you just have to understand it, and you have to embrace the possibility that it's true. Retaining is a bit easier, so just can they remember what's relevant to making the decision? I think if we tested lots of people, we would find it's really hard to retain lots of information about a difficult procedure. So I don't think, you know, the person needs to remember that 32% of people will have back pain after this process, or you know, in as much detail as that, but maybe that they remember that there's a risk of back pain. It's hard to test whether somebody's retained something without actually asking them. So you do need to say, I'm really sorry, I just need to check that you've remembered all this. Can you reiterate it to me, please? Because otherwise, if you say, have you remembered that? People just say yes. Have you understood that? They say yes. So you need to demonstrate their understanding and retention.
How long do they need to retain it?
Well, that's a really good question. It depends on how long the decision is going to take to be made. So if I'm going to make a decision now about doing something straight away, then a short retention is fine. But actually, if I'm making a decision about when I get home, will I remember why I mustn't drink? Then actually I need to remember all the time when I'm at home that I mustn't drink, or I mustn't drive my car. So it depends on the decision, and some things you need to remember in an ongoing way. weighing the information up. It's about whether the person can see both sides, whether they can consider, well, actually, I would like to go home, but there are risks.
Mm-hmm.
If I go to the nursing home, well, I won't be surrounded by all my familiar things, but I'll be a lot safer. They're just seeing both sides of the argument, really, and communicate. Can they tell you in whatever form? Gestures count, but you have to make sure that the person is actually making meaningful gestures, not just. So sometimes people will blink. If you say, "Can you blink once for yes, blink twice for no," and they'll just keep blinking once for yes. That sort of thing. If you're talking to somebody who can't speak. So before you see them, you need to be clear what the diagnosis is and what the question is. So people will say, "Can you go and assess so-and-so's capacity?" And you go, "Okay." Then you realize, well, what question am I asking? Because unless you know the question, you can't actually, you need to know the parameters. You also need to think before you go, are you the best person to assess? So for that neurosurgical procedure, I don't know anything about, it'd be much better assessed by the neurosurgeon than by me. It's good to speak to the people who want you to do that capacity assessment to gather what the pros and cons are and to understand what's happened to trigger this. So I don't know if the person's had a fall or they've tried to give lots of money away to somebody unsuitable or whatever. I always try and take a pen and paper with me and some information leaflets. That way, sometimes if somebody can't take it in verbally, you can write simple questions and simple points down and you can give them something to focus on. So TEP forms. So you've covered, I think, the front side of the TEP form already with Jay, haven't you? So if we just, not the back end, but again, I'm at risk of sucking eggs. The back side of the TEP form is a capacity assessment, and it does ask you to say what the diagnosis is at the top, and do you think the diagnosis is causing the impairment of the mind or brain? Because ideally you want that connection explicit between the diagnosis, the impairment, and the lack of capacity. As Jay's already said, I'm sure that it's good to do them early in people with dementia while they've got capacity, so that we know what their wishes are. I think that idea of telling people what's on the menu, whether their capacity is, whether resuscitation is actually on the menu for them, is a really helpful idea, rather than kind of saying, well, would you like it, when we'd never really offer it.
No, Jay talked about that, but if, we talked about that if somebody's already got a damaged kind of brain with dementia, and then the risks of kind of hypoxic injury, and
they're so high
on top that having a poor outcome. So Jay talked in terms of menu options. Is it on the menu? Would we be offering it, or off the menu?
I really like that new term. I really do. Some of the phrases I use when I'm discussing it is that I think a quick death with dementia is much better than a slow death with dementia. We can have people who take weeks to die, and actually just dying quickly of a heart attack would be much nicer. And also I think it's important to think about whether we're prolonging death or prolonging life, and that can be a useful phrase particularly to have with relatives. I think when you're at that end stage and if there's no TEP in place yet. So I bring the leaflet with me and I go through the form with people and fill it out in front of them. That's my way of doing it. And we've got this little leaflet that explains it, that's a CFT one. There's a very similar one for RCHT. I don't know if there's one for the community. Is there one for the community to use when you're seeing patients?
Not as such, I believe.
No. It's quite a useful thing to have.
Yeah, I think one's being developed. Actually.
Yeah, and they've developed an easy read version as well, certainly in our trust, which is good. So I think it's really, really important to communicate about it to people's loved ones. The last point I've put on my slide about the tension between the legal principle that people can refuse treatment but can't insist on it, I think that's really important, because a lot of relatives, they feel overwhelmed by being involved in these discussions, and they feel that they really ought to be asking for resuscitation. And I think it's vital that we communicate that it's not really their decision, it's our decision. We decide what's on the menu or not. and they can argue with it and they can ask for a second opinion, but it's not their decision, and we're not putting that burden of that decision on them.
No, a lot of people believe that they don't have to make that kind of
I
decision,
think it's a horrible responsibility.
They're not easy conversations, but that's why it's best done early on, and that's why we're trying to get an earlier diagnosis in dementia, so that we can kind of plan, do sort of advanced care.
Ideally, maybe not on the day we take the diagnosis, but soon after, very soon after.
First year.
So you've got to complete the capacity form on the back of the tab. If you're a CFT employee, you've also got to do the capacity form on Rio. If you're a CFT mental health, I don't know if you have to, if you're CFT in the wards, in the community hospitals.
We use the tech form that they use in the community.
And when the CQC visit, they go looking for evidence. We followed those 5 principles, and we've tried really hard to give people every chance to have capacity. So before I move on to power of attorney, is there anything to cover, do you think, about the capacity that we've covered so far and TAP forms?
Nothing.
That's okay. So power of attorney, this is something I think GPs often get asked to witness. So there are 2 forms, as I'm sure you know. There's health and welfare and property and affairs. And I think when you're assessing capacity for that, the key points are, does the person understand what the power of attorney is for? To understand who they might choose. I always advise people to choose someone who's got the time, who knows your taste, and who you trust. 3 T's.
That's good.
You can choose a friend, a relative, you can choose a solicitor, you can choose a financial advisor, all sorts of people get chosen. You need to understand, if you're choosing a solicitor or a financial advisor, they're going to charge out of your money. They need to understand that they can change their mind until it's registered. And if they're doing it jointly, whether they want it joint and several or just jointly, and that they can leave out the bit of life-sustaining treatment. That's quite a lot of complicated stuff that you have to assess them for, that they can understand and retain, weigh and communicate.
And they can have it for just health.
Yeah, you can have it for just health and welfare, or just property and affairs, or you can do both. And the health and welfare one includes life-sustaining treatment, life-prolonging treatment, I think might be the phrase in it.
But if you're a clinician looking after somebody and the relatives, your patient doesn't have the capacity around their decisions at that time, and the family say, we've got lasting power of attorney for health and welfare, you should sort of see a copy of it, shouldn't you?
And that's a really good point. So we've quite often had families say that, and they don't really understand, and they don't have it, or they've got it for property and affairs and not for health and welfare, or it's not been registered yet with the Court of Protection. So you can advise them to register it with the Court of Protection. So a COP3 form, I imagine GPs get asked to sign these all the time. They're quite detailed forms about capacity. In fact, it doesn't have to be a doctor. It makes it explicit in the form. It could be done by a social worker or a nurse. And you have to have seen the patient. You have to know the diagnosis, know a bit about it. And you can charge a fee for that. There's no fixed fee. And the fee is charged to the patient, not to the Court of Protection. I think it used to be £120 a while back, but now you can charge whatever you feel is appropriate. Do you get asked much about testamentary capacity in general practice?
No,
I get asked about that occasionally.
Experts more, I think.
So they need to understand the nature and effect of making a will, and, for example, that it can be changed. They need to be these rules come from a case called Banks versus Goodfellow, if you want to look them up. Who might reasonably expect a bequest. They need to know the extent of their estate. So if they've got nothing and they're trying to give away £3 million, then that's not capacity. And we need to exclude that any mental illness that somebody's got isn't clouding decisions. So if you think that your husband is a very evil person because of a mental illness and you're not going to let him inherit anything, then that's probably not very valid. But if you think you just want to leave the money to your children instead, then that probably is. It just depends on the reasons. So there's a golden rule that if a solicitor encounters someone who's very frail and possibly mentally ill in some way, they should always ask for a medical second opinion. Place of abode, so that's often whether people should go into nursing home, residential care, that sort of thing.
Yeah.
Where I've written URWC, that's understand, retain, weigh and communicate,
Okay.
which I remember as you are a toilet, URWC.
That's very good. I like the acronym, that's very good.
So again, they just need to consider the risks and benefits of each alternative. And the financial risks there might be financial risks in moving somewhere more expensive. There might be practicalities. It's a long way from their family. It might not be where they prefer to be. They might prefer to be at home, but it might be more safe. But some people will say, I'd rather fall and die than go into a nursing home. And if they're making that decision, if they're going through all the steps, the understanding, the retaining, the way and the communicating, then they've got capacity to make that decision.
Yeah. And that's the same if it's a temporary kind of move, if somebody's going into respite, or if it's kind of a permanent, permanent move. Same thing.
If the person doesn't have capacity and is going to respite, you could look at DOLS once they're there. DOLS applies to a place, not to a person, so you can't use it for transport unless you go to court. So medication, again, you need to understand, retain, weigh and communicate. The phrase used in the Mental Health Act regarding mental health medication is the nature and purpose of medication, but I guess it would be the same for physical health meds. If the person lacks capacity, you need to consider the best interests on the refusal. And so you're using the Mental Capacity Act. You can only use the Mental Health Act, obviously, if the person's detained. And even if the person's detained in a psychiatric hospital, it only applies to their psychiatric meds, really, unless, I don't know, say their diabetes meds are affecting their mental health. But I'm guessing for most of this audience, there are people who aren't in psychiatric hospitals, working in psychiatric hospitals.
No, they might be in a care home or a home or community hospital.
So if there's an advance refusal, we ought to know. So, for example, recently I was looking after somebody who had refused all her life to see anybody about very long-standing gynae problems, and it felt it would be wrong. Now she had no capacity to kind of force that process on her, and it would be the same if somebody had always refused to take diuretics, or if somebody lacked capacity for a blood transfusion and they're a Jehovah's Witness, you wouldn't, if it's always been part of their wishes, you need to bear that in mind. It's worth consulting people's family. People are allowed to make these advance refusals now, ideally in writing, but apparently it can be spoken. So we have to actively look for them. If we're considering covert medicine, which I believe is probably used a fair bit in nursing homes, people who are refusing their meds, there are several stages to go through. So first of all, you've got to assess capacity with all we've just talked about, establishing a diagnosis and whether they understand, retain, weigh and communicate. Then you've got to consult with multidisciplinary team, with the family or the whatever stakeholders there are.
So I guess for somebody in a care home, staff in the
care home, persons, visitors.
Or what might be district community nurses. Community coming in.
Asking them what they think about each individual drug. Then it's worth talking to pharmacy, because they'll have views about what can be crushed and what can't be crushed, and what can go in cold liquids and what can go in hot liquids, what can mix with yoghurt. And there'll be a whole complicated list of what you can do. And then once you've pulled all that together, to document it in a covert care plan.
It's always a good time to go, actually, do they need these medicines? It is. A bit of de-prescribing.
It's ideal.
Actually, what are these for?
Do we really need
these?
All these antihypertensive agents at this stage of our life,
or
when we're falling over.
Cholesterol tablets,
and bone protection. So another scenario that I think probably comes up is refusing admission to hospital.
It is. People do say, actually, I don't know, I'm not going anywhere, I don't want to. Quite happy in my own home. I'm not going anywhere near Derriford.
And I'm sure other hospitals will refuse too.
Although sometimes you do have to check. I'm not going near Derriford. You do have to kind of check sometimes. would you go to Exeter or Trellisk? Oh yeah, I'll go there. But
yeah,
you do have to check sometimes.
And sometimes somebody's, I don't know, they've lost a partner in one particular hospital and it's got too much meaning for them or whatever. Yeah. So if they've got capacity, we have to respect their decision and document it. And again, that's looking at, you know, what are the pros and cons of going to hospital? What are the risks? Actually, sometimes people don't really need to go to hospital, do they? No. Then if they lack capacity, we need to decide on their best interests. Now, if it's an emergency, consultation can be limited. So I don't know, if somebody's leg is cut off and they're bleeding quite heavily, you might need to say, oh, he lacks capacity, and just having assessed it, and just send them without actually talking to the relatives. But you know, so a lot of the time there is time to actually ring up relatives and ask, you know, what do you think is in their best interest? What's the least restrictive option? Could we get the district nurses in? Is there a care at home package? That kind of thing. Or would they go to a community hospital instead? Though I appreciate that might not be appropriate. I wouldn't go against someone's wishes admitting them to a DGH lightly, I think, because you're going to have a hard time then looking after them once they're in. And it's going to be tricky. And whatever you do, I guess, to document it carefully. So where's my little arrow? So legal powers. So I guess you'll be looking after people who've got power of attorney or deputyship or appointeeship, that sort of thing. So somebody's power of attorney, they can act as though they're you. They can make decisions as though they're you. They can decide to accept or decline surgery. They can, if they've got power of attorney for health and finances, they can sell all your shares, buy your shares, sell you a house. They can do all sorts of things as if they were you. Deputyship is a bit more of a clumsy piece of paperwork. So power of attorney you make while you've got capacity, and you sign the forms while you're fully sort of compos mentis, or mostly, as long as you've got the capacity to do the forms. Deputyship is done after you've lost capacity, and your family usually apply to the Court of Protection to be granted deputyship. Power of attorney is not, to, as far as I can see, monitored nearly as closely as deputyship. Deputyship is really carefully watched by the Court of Protection, and I guess that's because the person hasn't chosen it themselves. There doesn't seem to be nearly enough scrutiny, I think, of either of them.
So the deputyship can be the same as the power of attorney has health, welfare and finance. The deputyship, does that just have finance or health?
I think it's mainly health, but actually I don't know. Worth looking up. And then appointeeship is something that only covers state benefits, and it's usually done by a state employee, so a social worker or an admin person, and it's really just looking after the finances for somebody who can't look after their money anymore. Deputyship can cover where you live as well. I remember somebody being moved to Scotland under deputyship, and it raised all sorts of questions because the person had lived in Cornwall all their lives, and you sort of wonder, would they have chosen to go up to Scotland to be near their family? No idea. No idea about how comfortable, you know, they would be when they got there. So driving is another big deal, isn't it?
It is.
And it's emotive because Cornwall doesn't have great public transport. People really value their autonomy. Very often there might be one spouse who drives and one who doesn't. And so that person who doesn't drive has a vested interest in keeping their spouse driving as long as possible. If somebody's got a diagnosis of dementia, then they must inform DVLA of that diagnosis, and that puts some people off coming forward because they don't want to give up driving. They don't have to tell DVLA if they've got a diagnosis of MCI, and we know this because we actually wrote to them and clarified.
That's mild cognitive impairment.
If they don't inform DVLA and you've got reason to be concerned, then we actually have to wonder whether we've got a duty to breach confidentiality on their behalf and tell DVLA. We should also inform them that they must tell their insurers because it changes their insurance. once DVLA have got the information that the person's got dementia, then they can request a test, not very far from here, so over there somewhere,
Okay.
at the mobility centre, where they've got a great setup, and they do an assessment where they, first of all, they put you in a sort of simulation centre and check that you can work controls and understand the main rules. They check that people can read signs. They can look over their shoulder, that sort of thing. And then they take the person out in their own car. They'll also look at whether there are adaptations. So you might be able to have a mirror extension, for example, if you can't look over your shoulder. So they're a very fair test. It's much, much cheaper if you're referred through DVLA than if you just choose to go there yourself. So it's worth waiting to be referred. And they will advise whether people are still safe to drive or not. The bar to keep driving is quite high. So a lot of people, they're safe pottering around on local roads near their house, but actually they need to be safe to drive on all roads to keep their licence. So if you write to DVLA and say this person is quite safe driving around on local roads, they'll say, we don't care. They have to be good enough to drive anywhere. They might forget to drive just on local roads. But I think still it can be a useful thing to say, particularly if you're copying the patient in, because they can see you're still fighting their corner. And patients, I've encountered patients who've never forgiven me for stopping them driving. It's a massive deal to them. And I think, if it's going to be a big deal, if you know in advance, it might even be worth, if you're the person's GP, sort of negotiating with the psychiatrist who's giving the diagnosis or might be involved in the care, whether it's worth sharing that burden or deciding that one person's going to be the bad guy and not have an ongoing relationship. I
think those sorts of GPs can diagnose dementia, but I think in these sorts of cases where there are kind of sticky issues and legal issues, it's certainly worth referring to get a psychiatrist.
I think
input,
so.
Actually, I think
it's and you can never re-establish trust sometimes.
No.
It's people care about their costs so much. So resources, I think we're probably running ahead of time, so I've put together some resources. So the Mental Capacity Act, you can look that up online. The Code of Practice is really easy to read. Never read the original law, it's awful and impenetrable. Read the Code of Practice, and it's nice, and it's easy to navigate, and you find the bits you want, and it's very clear. And the same for the Mental Capacity Act, which the updated one actually contains quite a lot about the interface between the Mental Capacity Act and the Mental Health Act, when to use which one, and when to use DOLS, when to use detention, the Mental Health Act. I thought I'd put in a bit about the Cheshire West case. I don't know if the ramifications of that sort of went into general practice, but
I think I think a lot of people have kind of heard of it. But it's good to recap because it's massive. So what the judges said was that a deprivation of liberty is when somebody's under continuous supervision and control and can't leave. So a locked door, continuous supervision, control. That doesn't mean continuous supervision control being watched all the time, but it means being controlled all the time. So they established in this particular case that it can even happen in your home. You can have a doll at home, which we had previously thought wasn't the case. If it affects who you mix with, that sort of thing, when you go out. So that's regardless of whether you agree with your detention. So you still have a deprivation of liberty if you're agreeing to it, and even regardless of what the purpose is. And you shouldn't be measured against what someone else might think is a normal life. Say for somebody with dementia or learning disability, you should be measured against what normal life is for everyone. So if somebody's living at home and their family put up cameras, because some people put up cameras to kind of monitor them,
that probably is a slight. It depends on whether, because you need to have both the continuous supervision and the locked door. But some people do lock the door at night to stop their relatives going out, which is a bit of a fire risk if they're the only person in the house. And then if you have cameras, you might have to go to court of protection. It's a very involved business going to court of protection. So this led to chaos, really, because people in intensive care were effectively deprived of their liberty.
Yep.
All sorts of people were deprived of their liberty who really, it wasn't what the law was intended for. So there's now been further case law saying that actually it's not meant to cover all those other situations. Really, it's about people with dementia, learning disability or mental disorder, living in sort of hospital or home-like environments, but it's not about unconscious people. And it can also happen in a domestic situation if the state is imposing the rules. So yes, the situation we're talking about, relatives locking doors and putting up cameras, that's okay because they're not the state.
Okay.
So
supported living, Okay, so so if somebody was, say, in a residential home or in the community hospital, we have it quite a lot as well. We wouldn't want that person to leave. It often gets kind of confused because the staff say, well, they're not trying to leave. So, but actually, if you'd stop them, they would need need a DOLS in place.
I think it's always worth applying. And then when the DOLS people come, they can say, oh, it's not necessary. But what that is saying is it doesn't matter whether they're consenting to it or not. And it doesn't matter, if they have to be there and they have to be, and you would stop them leaving, then you should really apply for a DOLS. But I don't really know if that's what they ever intended, but we should probably...
It's quite a lot of work. So can you tell us a bit about the DOLS team? DOLS Deprivation of
They're amazing. So first of all, when you first do a DOLS, it's done by the place that's holding them. So that's done by the responsible authority. I can't remember the proper term, but the something authority. And so in my case, it'll be the ward nurses will fill out a DOLS form, and that works for 2 weeks. Then you can have a 1 week extension.
That's sort of an emergency.
And then they'll do a standard authorisation. So the DOLS team will come. So for Cornwall, they're based, I think, largely. I don't know where their office is, actually. It used to be in Old County Hall, but they may have moved. But there are a few scattered county-wide. So they're called DOLS assessors, I think, and BIAs, best interest assessors. And they're often also AMPs, approved mental health practitioners, but they don't have to be both. And then a GP can be, or any doctor can be the capacity assessor. I think it's largely been commissioned to a particular company who provides medical assessments of capacity. So our local GPs, I think, don't do it so much. And they come out and they make a very thorough assessment. They fill out an enormous form, and then it has to be reviewed every now and then. They can specify what's allowed and what's not allowed. So they can say this person must be taken out once a week minimum. They must have, I don't know, the opportunity to speak to their daughter once a week, or they can make all sorts of things, all sorts of conditions. The next thing I was going to mention was the Dying Matters website, which is ever so helpful, looking at stuff around TEPS, capacity, all sorts of resources, training materials. Another one, if you're interested in mental health law, the Mental Health Law Online website's really good. And should you ever need the paperwork, they've got every single form that you could ever need in the black bar at the top of the screen. It says main MHA, MCA forms. They've got all the forms you could ever need for the Mental Health Act. You just need some pink paper to print them out on. But you can print them on any colour paper you like. They do a good newsletter on mental health law, which you can subscribe to, and it gives you regular updates on changes in case law, which is quite interesting. There's lots of firms of barristers and solicitors who do newsletters. This one is one I subscribe to. They do these little updates. This was the one where they explored this very idea of deprivation of liberty in a hospital setting, and where it applies and where it doesn't. And it's very clear and useful. and written with a small amount of humour too. So it's quite good. So again, you can subscribe to their newsletters.
Okay. Are those ones free, or do they just?
Yeah, all free.
Oh, that's quite
free
good.
from solicitors. Yeah, very good,
isn't it?
So I think that is the end of my talk. Yes, it is. So I
no, I think that's really useful.
Time. 12:21.
Yeah,
no, it can't be. I know that's when I took the picture.
No, it's really useful. It's a really good summary. I think some of the legal issues can be quite sticky. I think, especially around the mental capacity and making sure that you've sort of assessed it. I think remembering your acronym, which I've forgotten already.
You are a toilet.
You are a toilet.
You are a WC.
Yeah.
It's
very good, actually.
I have to say, my capacity assessments have been honed by court appearances. So hopefully none of the audience will ever have to do this, but standing up in court and explaining exactly what you've done and why you've done it, that makes you, when you've got a very sharp barrister on the other side cross-examining you, it does make you understand the need for each step very clearly.
Yeah, no, definitely.
So that's what I have in my mind when I'm doing it, and also when I'm documenting it.
Yeah,
it's not often that these things are challenged, but it's happened to me a couple of times in my life. So I guess it probably happens a couple of times to other psychiatrists.
And as a community kind of, if you're working in the community nurse, GP, and you need a second opinion on somebody's capacity. So sometimes it can be difficult.
Yeah.
If it's, for us in the community hospital, if we're making a capacity assessment around somebody being kind of discharged and discharged home or to a care home, then we'll get a second opinion from a social worker. But actually, around somebody's kind of refusal of treatment, or is that something that a psychiatrist would?
I've been asked to do it, and I felt it was completely inappropriate for me to decide whether somebody has a gynecological procedure, because I don't know the pros and cons.
Yeah.
So I think the person who should decide is the gynecologist.
Okay.
Or it depends on what the treatment is, because you need someone who actually knows what all the risks and benefits are.
Okay.
And a psychiatrist, I know about the risks and benefits of psychiatric treatments. I don't know the risks and benefits of an endoscopy.
No. Okay. That's quite, I'm trying to think of some examples, but that's quite useful, actually.
Yeah. I mean, you can always ring up a psychiatrist and have a conversation about how you might do it, what questions you might ask, how to frame it, that sort of thing, what you might do to improve the person's capacity, to get a bit of help. And I've certainly given that advice over the phone quite a few times to colleagues. But whether they're the right person to do it is another.
There was a case recently that one of the GPs discussed with me that were concerned about the patient had presented for quite a while with symptoms of dementia, but they were still drinking alcohol, and they're really struggling. Do they actually have the capacity to make the decision around drinking that alcohol? Really tricky.
Yeah.
I mean,
and sometimes people do remember, and sometimes they don't, and that's tricky. And then you have to decide, if they don't have capacity, what's in their best interest? Because is it in their best interest to make them go dry, having expressed a lifetime wish of drinking? Or is it in their best interest to actually enforce sobriety on them?
No, fair enough. And also, if somebody, the other thing with dementia is obviously not, you can still have capacity, but later on in the illness, when it's more advanced, people can lose capacity and insight to even having dementia, aren't they? And we sort of refer people, okay, we want a diagnosis, but they don't have the capacity to consent to having a diagnosis. How do you guys handle that?
Well, I don't work as an inpatient consultant. I'm working largely with people who've gone way past that. They may not have a diagnosis, but I'll make it as part of my process. But
that's why they're with you, aren't they?
Yeah. You're talking more about people who won't go to the clinic.
Yeah, but sometimes there are circumstances where we do have to diagnose somebody in their best interest. Otherwise, we can't get them the support.
Services that they need. So you could ask for a home visit. The person still needs. I think a lot of psychiatrists have difficulty about forcing psychiatry on people because psychiatry, in the past has been misused. And so there is, although there are times when you have to force psychiatry on people, you'd need to make a risk assessment about whether it's in their best interest to go forwards. But sometimes, as you say, it is in people's best interest to have a diagnosis, and then You could, if the person won't see you, you can make the diagnosis on the information the family give you, and you can just make it really explicit and write a letter. I haven't met this person, but based on the scan that you did 2 years ago and the history we've got from the family of 5 years of decline, and the fact that I'm told that he can't remember this, that and the other, and his words are muddled, I think it's safe to assume that they might have Alzheimer's disease or vascular dementia, or just dementia. You might not be able to say the subtype. But then at least you've got a diagnosis of dementia, and that opens the door to care. You know, it enables carers allowance a bit easier. They get a reduction in the council tax, might get attendance allowance. So there's
lots of benefits to it. Often it can help the carer.
And also I think if you are a carer and you're looking after somebody and you don't know what's wrong, that's really stressful, and you can get cross with them. Whereas if you know, well, they're ill, they can't help it, then it gives you a narrative to work with, and it also gives you something to say to other people. For example, we can't come out, Ron's got a bit of dementia now and he'll get confused after more than a couple of hours, or we'll need to leave after half an hour because he can't tolerate more than that, and it gives you a kind of, it helps the social situations a bit better, it oils them, it lubricates them a bit, having the right words to use rather than, we can't come.
No, I think, and it's good to kind of to help carers, I think, in that sense, isn't it?
Yeah. It's a hard job looking after somebody with dementia. It's really, really demanding. If you're the only person there 24 hours a day, someone you love to bits, the person you'd normally talk to about your troubles, you can't talk to them. And it's lonely, you can't leave them alone. Yeah, it's tough.
Hard thing. So it's been a really good series, actually. Of the sort of 5 webinars, we've covered lots of information, actually, and I'm so grateful to you coming for the sort of the final one. Really, it's been really good, really good system-wide project.
Well, thank you for inviting me.
Brilliant.
Cheers.